Okay, I'm gonna just start with a little introduction. Hey everyone, this is AJ, and I want to start by just thanking you all for having a great VLC session. Welcome to session 6, our final session. On behalf of SNAC, I want to say thank you all for all your hard work and participation throughout all of these sessions. We're really excited to see how these VLCs can impact your work in your organizations and what we can do moving forward to keep that situation working out very well. And I think I can speak on behalf of the Optum team by saying that we really appreciate all the hard work you guys have been putting in. One thing I wanted to mention before we get started is I do still have that learning summary template, which I sent out to all the team captains last week. If you haven't done that, that's attached right here as a file. Please get that sent back to us at SNAC. We really appreciate your feedback and how we use that to kind of see how the VLC was impactful for you and your organization, and kind of how we can use that for learnings moving forward. Anyone's welcome to do that. I'll be following up with the team captains to make sure that they get those done specifically, but if anyone else wants to do that as well, that'd be great. And other than that, I know we're doing all presentations today, and I'm going to let Natalie and Sherry take over.
Okay. Do we have somebody from each of our partners on the phone? I see Kelly from Alaska. Oops, sorry, I'm getting rid of that. Who else? Who do we have from Alaska?
Hi, it's Leanne Horn and Deb Seidel.
Okay. All right. And we've got Cascadia.
Hi, this is Renee.
Hey, Renee. We've got Ventures Network, Collaborative
Jenny
Ventures
Roberts.
Network. Okay, Jenny. Healing Community Center. Okay. Anyone from Hudson River?
Hi, this is Allison from Hudson River Healthcare.
Okay. Southern Illinois. Tracy, I see you.
Tracy.
And Vinay. I don't see Laura,
Yep,
but maybe
this is
Laura.
Laura Barrett.
Hey, Laura. Okay. So this is our last session here. The topic here was clinical integration across care settings. And we had hoped that by the end of this, participants would come away with an understanding of value-based contracting models and the related implications for integrating what you do across care settings, because most of you aren't, part of big integrated delivery systems. Therefore, you've got to invite others into the neighborhood. So we also hope that you would be able to identify the fundamentals of building a strong healthcare neighborhood, meaning, figuring out what it is your patients need and who it is you're going to partner with and how you're going to get them to partner, and then how you're going to monitor the partnership ongoing. And then, other requirements for supporting integrated care systems and otherwise collaborating, whether it's health information technology, shared care management models, legal and data sharing, et cetera. So we hope that these sessions have been helpful to you in understanding more about integration across the clinical settings through addressing those types of topics. And if we're ready, why don't we go in order, and we'll have our Alaska friends maybe go first. Alaska, that okay with you? Team captains from Alaska?
Yeah. Yep, that's fine. And Annie, are you on the phone?
I'm here, yes.
Awesome. All right. So Annie Dursick, she's a PhD and works in behavioral health at the Providence Family Medicine Center and the residency. She's the group visit clinical therapist. And she has offered, she wasn't even voluntold, she volunteered to give our presentation. So thank you, Annie, and I'll turn it over to you.
Sure, no problem. And please, I just want to invite all the Alaska folks who've worked on this to please jump in and add something if I miss something important there. So under the first component about participation and conditions of participation, we would create a physician hospital organization using the PCMH as our structural model. The participants for our group would be the system hospital, which is Providence Alaska Medical Center, the local critical access hospitals, hospital medical group, which is PMG, our local family medicine center, local PCPs, local specialty providers, post-acute care providers like Providence In-Home Services and Extended Care, Transitional Care, and local home health and SNFs would be our participants. The conditions that we have for participation are first to agree to participate in the collection and sharing of data specific to clinical performance and outcomes. Also, individual performance would be evaluated against agreed upon standards. Participants would be willing to be subject to remediation efforts if performance was not up to par. Also, transition to a single IT platform. In this system, we use Epic, or agree to use the HIE, the Health Information Exchange. Financial incentives that are aligned towards common objectives would be utilized. Participants would adhere to evidence-based clinical protocols in order to reduce unnecessary clinical variation, and they would collaborate in a prescribed set of quality and performance measures. So our rationale for these conditions would be that they allow the larger group practices and the PAC providers in Alaska to align with the hospital system while remaining an individual/private group practice. Also that the need for a cross-continuum of providers if the ED and IP reductions are the focus of shared savings. Patient data must be collected, stored, and easily retrieved across all of the providers, so that would be necessary. Establishing a network of providers also enables enhanced coordination of care, and performance improvement initiatives must provide a demonstrated value to the patient and market. So under the next component, which is the exit criteria, if the provider is excluded from participation from any federal or state healthcare program and violates the terms and conditions of the agreement for any reason within the 60-day notice. The provider exiting from the CN would be under the conditions of violation of law or regulations, including antitrust, HIPAA, high-tech, Stark, and anti-kickback for any reason within 60 days of notice, with 60 days notice, sorry. The rationale for these criteria are a legal requirement of establishing a contractual agreement between a hospital and provider, and within the agreement there must be written terms for termination for both the CIN and the provider. Okay, so moving on to the next component, top 5 partner accountabilities and roles. The first is to establish a legal contractual relationship that must ensure antitrust, Stark, and anti-kickback rules are adhered to. The CINs are a legal structure, not a payment model, and the CINs must establish clinical integration. Next, number 2, provide physician leadership and shared governance, because hospitals must empower physician leaders to have an influence on the future direction of the CIN and aid in buy-in. This is very important. Number 3, create a participation criteria. Participation criteria is important to outline the expectations and requirements for participations in the CIN. Members must adhere to these criteria to help ensure stated objectives are met. Number 4, develop standardized performance improvement measures. Performance improvement is an essential component and is a vehicle that engages physicians in determining how quality is defined and measured. And then finally, number 5, develop standardized IT platform because it is essential for data collection and coordination of patient care across the continuum. The goal really is to create shared disease registries and disease management systems. So finally, the last 2 components, the performance initiatives. First, shared savings provisions from a reduction in ED utilization and 30-day readmissions. Because if cost is reduced and quality is improved, then the entire CIN will benefit from the shared savings. that they receive from the MSSP program. Also, opportunity to drive healthcare quality and value in order to develop future contracts with federal, state, and commercial payers. What are the terms in the event of low performance? The first is remediation. Providers must be willing to share individual quality and cost data. They must be willing to seek or receive additional training if necessary. And then ultimately would be exit. If continued low performance after remediation persists, then providers would need to exit. Oh, did I miss anything important, Alaska?
This is Leanne. You did fantastic. Thank you so much, Annie.
You're welcome. Okay.
So as you were doing this, how did you think about the difference between exit criteria, which seemed very kind of, okay, you can't violate laws and regulations, versus the terms in the event of low performance and, up to and including getting kicked out of the network? What were some thoughts about, other than violating legal or regulatory issues, what sorts of things what sorts of things did you discuss as sort of trigger events to jet someone out of the network for low performance? How concrete did you get?
Yeah, this is Leanne. We struggled with this one because this is all just kind of visionary and mock, in all sense, because, in Alaska, we haven't entered into any clinically integrated networks, nor real ACOs, that involve the community providers. So we kind of saw exit criteria as the more formal, what would we do? What would a provider do that would cause us to want to exit them, and what would we do to a provider that would necessitate them wanting to exit the CIN? So we kind of just stayed very basic. We didn't really go into the nitty-gritty just because we don't have a lot of experience with that. And then looking at the low performance, again, that exit from the CIN, it was the same thing. If the performance was low after remediation, then we would ask them to exit.
Okay.
So I'm looking forward to hearing of the other organizations because we really did struggle with that one.
It's a really hard one. It is, because there's the excitement of sort of getting things together. You're forming this clinically integrated network. You're talking about integration. The last thing you want to do is think about, well, okay, what if this doesn't work?
Right. And also, so Deb mentioned too, that we're such a small community and a small community of providers that it would be really difficult to be loose with our exit criteria. So we'd have, they would have to be a significant offense or something that happened, for us to exit them because there's just not many providers in the area.
Okay. And so you sort of settled on, it sounds like you settled on or aligned around patient-centered medical home as your kind of your care management model. What kind of a discussion was that with the group? Was that an easy one, a hard one? Did you say, what about that?
That was easy because it's our only model that's implemented in Alaska right now. And so that's the one that we know. Like I said, I think in the very beginning, Alaska doesn't have a single managed care organization. We're strictly fee-for-service. Specialty providers don't join networks. We're really we're really early. We're late adopters, but really early in the discussion. So PCMH was our natural place to go because the Family Medicine Center and Anchorage Neighborhood Health and Kodiak Community Health Center are all patient-centered medical homes, and so that's where the experience lies.
Okay. Great. Questions for the Alaska group? Consortium, I should say. Feedback for the Alaska group?
Great job. Yeah, this is Laura from VNA. Wow, I'm impressed. That was great.
And again, kudos to Annie for volunteering. Thank you, Annie.
What was the term you used, Leanne? You voluntold?
She volunteered versus
No, I
voluntold.
didn't have to voluntold her. She volunteered.
Never heard the voluntold. I like that.
It's on my list to be voluntold, though.
Okay. Cascadia Behavioral Health. You want to go next?
Sure. Hi, this is Renee. We're up here in Portland, Oregon, primarily a large behavioral health organization. So the partnership agreement that I'm working on is very apropos in terms of it's going on in real life, so that was helpful. But we're working with a hospital medical group to collaborate to provide physical health care services at 3 of our outpatient clinics in a way that upholds the requirements of the Certified Community Behavior Healthcare Clinic designation as defined by SAMHSA. So that's kind of who, it's just two of us participating here as we flush things out moving forward, and this would be a very early kind of MOU in that we'll start talking about things and recognize that we'll need to solidify things moving forward. So what we have is a partnership between behavioral health care and primary care out of a hospital system. And the goal is we want to drive down high utilization of our shared members because we have a lot of data on them, and there's certainly opportunities to do better, as well as increase access to integrated care services for shared clients in the 2 provider systems. So when I was looking at the exit criteria, I largely included the kind of the legal jargon. Really around, we can terminate immediately or at another mutually agreeable time with both parties consenting. We can terminate the agreement by either party for any reason within 30 days with written notice to the other party or sooner if mutually agreeable by both parties. We can immediately terminate the agreement upon written notice from one party to the other that their board of directors requires the termination. Immediately upon written notice from one party to another that they have concluded the negotiations over the activities and services. Immediately upon written notice from one party to another that their involvement in a project is not financially feasible anymore, that they do not have the capacity, or that their strategic kind of direction has changed. So all the stuff that I included is really kind of the way to get out legally. But I think also the other things that I would include maybe in the next phase as the partnership is further defined are really, tangibles around not either providing X, Y, or Z to the other partner, not delivering X, Y, Z as was agreed upon, or not achieving the certain outcome. So now just kind of really legally based, and then as we move forward, I think the agreement would be certainly include outcome-based as well. And in terms of partner accountabilities and rules, I jotted down a few. For example, Cascadia Behavior Healthcare is responsible for strategically designing a behavior healthcare model in keeping with Certified Community Behavior Healthcare Clinic requirements. Cascadia is responsible for developing and submitting all the documents as required by Oregon Health Authority's CCBHC application process. And Cascadia will strategically design the administrative services that will be provided by Providence Medical Group at these clinics. So Cascadia Behavior Healthcare and Providence will collaboratively work together to strategically design a model of integrated healthcare services at the clinics to meet the CCBHC requirements, as well as other requirements maybe by Oregon Health Authority or other payer requirements. The 2 organizations will design a financial model for all of the clinics that is sufficient to meet the needs of both parties. They'll strategically design an administrative and IT model for the services that will be provided by both parties at the clinics. Identify partner agencies necessary to provide other clinical services for the clientele at these clinics, and then strategically design, assign, and plan other services deemed necessary at the clinics to effectuate on the purposes of the memorandum. And really, of course, the rationale behind these is that we need to outline our partner roles in terms of being able to accomplish the goals, and that needs to be really streamlined and transparent. So some of the performance incentives, really what prompted the conversation is around decreasing utilization of ED services for Cascadia clients within the Providence medical system. So our performance incentives will be percentage of money saved through reduction in hospital ED costs for shared clients, as well as overall decrease in Cascadia clients being admitted to the emergency department. The reason for those performance incentives is that is what is really kind of driving the conversation and the relationship, and we want to make sure that people are accessing the resources and care at the appropriate level and not overutilizing it. So what are the terms in the event of low performance? Because we're kind of going into this not really knowing what it will look like or how we're actually going to execute this quite yet. I'm just kind of working off the idea that we'll model a pilot for 12 months. And throughout the 12-month pilot period, we'll look at efficacy, sustainability, and ability to continue partnering with both agencies because, it's kind of new and it's early on and we're not quite sure what's going to work or how it's going to work. So we want to continue to explore what works as we move forward and develop this, and then continue to reassess and reevaluate not only the services but the feasibility of an ongoing partnership. And I think that is about it.
Okay. So in this way, you're kind of managing towards, you've got a 12-month period of time and then an explicit kind of re-up criteria or let's stay together, let's stay integrated. So that's a different and interesting way of handling exit criteria.
And I think my experience with working on MOUs and BAs and all this other stuff is it's often multi-phased in that, for example, we might be applying for a grant where we have to have, we have to have a committed partner, and you're not quite committed to, you want to work together, right? But you're not sure what that's going to look like. So I've just found that we very often kind of started with an MOU to agree to work together and collaborate on whatever the project is, and then as we are able to kind of hone things in, that's where we get into more of the detailed language and expectation and things like that you would often see in a business associates agreement.
Okay. So in the event of a dissolution, who would keep what assets or investments?
Well, the way that I'm thinking about it is that because funding for integrated care is still separated out between, physical health and behavioral health, the behavioral health organization that brings in behavioral health dollars will hold on to that, just like the hospital group that brings in primary care and specialty dollars will hold on to that money as well. So I think really it's more around the partnership of sharing information and sharing strategy to decrease ED utilization.
The downside of a limited engagement is that it can be a disincentive to invest in infrastructure to integrate, for example. So you're going to figure out how you're going to data share. You're going to figure out what your clinical model looks like together. It's got to be mutually agreeable, which are all good things.
And we're charging them too. I mean, there's not a lack of financial investment. It's just that I think for where we are in this process, we haven't quite identified what that will look like because we're still, sketching out the business model. However, I mean, we know that, for example, if we have a primary care provider come on site, not only does that mean that we'll have, exam rooms and a desk space, but, also having pharmacy and, lab and all that. So there will be, I think probably what we'll end up doing is like renting the space in our building to the primary care group so that would probably be how the financial investment flows just due to some of the complexities around how money can be shared, what can be shared and all that good stuff. So my apologies, I didn't include the financial piece because we're still very much figuring it out, but there will be financial investment, but in terms of shared financial, I don't know that we're quite there yet and that we'll figure out what that will look like.
Okay. And then performance incentives. So it's interesting because you're going to partner with the hospital and a group that is affiliated with Providence Hospital. Is that right?
Providence Medical Group, yeah.
Medical group. Okay. All right. And then together, there's assumed alignment around reduction of, unnecessarily inpatient and ED utilization.
Correct.
And so there's agreement from Oregon is complicated in that you have the CCOs, that they seem to have sort of geographical capitated budgets that they then distribute among payers. And so how then do you, that's a lot of moving pieces to organize in terms of performance incentive alignment.
It is. I was hoping we'd get all the answers here so then I could bring it back and actually, implement and execute. But there's still a lot of things to figure out for sure, and like how that will look like in terms of money being saved. I mean, I think, that's what we're in the process of figuring out. I can tell you how many Cascadia clients were admitted to, the psych unit or the just the regular ED within Providence Medical Group over any period of time. We can tell, we know how much money is attached to that, but how to share cost savings, right? How to measure cost savings is challenging. And then how to share that among different providers is certainly as challenging, if not more. So I think these are pieces still, trying to figure out who's doing the financial investment on what pieces, not only the infrastructure, but the staff and the services, and then how is the money recouped. And again, it's just really challenging when you have, one person who has, different payers for their body, depending upon what types of services are being provided. So as a behavioral health organization, we still don't really have access to a lot of physical health dollars. And we just need to figure out who's billing what, how things are being saved, and how things are being paid for. And it's really complex.
Yes. Okay, questions or comments for Renee? Feedback for Renee.
Hi, this is Leanne. So I'm excited that you're working with Providence. I didn't know that you guys were collaborating on this project. I think it's really cool, and I'm really excited to reach out to my peers at the Providence Medical Group in Oregon so I can follow your journey. Also, I was really I was really appreciative of you saying that an MOU is a great place to start, where you agree to collaborate on a specific project. And so I think that's exactly what we're doing as the Alaska Care Management Consortium, is I have MOUs established with all of the organizations that are participating, and it's kind of our first step in, identifying what does collaboration look like, what can we do together, but in a safe, non-financial environment. So thank you for calling that out. I wrote that down because I think that that's important to relay to the rest of the group.
Yeah, thank you. I appreciate you saying that. And, I've been kind of keeping Alaska on my radar in terms of what's going on with health transformation, because I think you guys are doing a lot of really cool things up there. My in-laws also live in Anchorage, so I might be reaching out to a few folks when we make it up there to visit to see what's going on.
Yeah, definitely. Let me know. I will hook you up. This is
cool. Thank you.
Okay. Anything else for Cascadia Behavioral Health? Good job. Okay. Collaborative Venture Network.
Okay. I hope the volume's okay. There was feedback on that last one, so I kept on turning it down. Collaborative Ventures Network is actually in the process of creating a clinically integrated network, so this is very timely for us, although the question posed is a little different than where we're going to start out. So I tried to map how we would approach this if this was our given environment. We're a statewide network, meaning all of our federally qualified health centers, lookalikes, and actually one of our rural health centers participates in Collaborative Ventures. So it's a separate corporation from our primary care association. Collaborative Ventures has very few providers that actually have admitting privileges, that are rounding on their patients in the hospitals. We do have a system here in Arizona where a lot of our hospitals have hospitalists, and so there's those agreements where the hospitalist will round on patients. So trying to create a collaborative environment for with the hospitals is very important, so that information is shared both when the patient is admitted or presents at the emergency department, as well as getting that information back to the primary care physician who acts in the medical home. We, under our initial agreement for participation in our clinically integrated network, we're not contemplating bringing in hospitals or specialists. It was to be a clinically integrated network of primary care providers through the health centers. So what we would look to is memorandums of agreement to establish that collaborative partnership with the hospitals, depending on the community where our health centers have their sites and their locations. So that's, I'm actually giving you all the rationale before I give you my response. So who can participate? It would be the health centers. Requirements for participation would also include that our health centers participate in our statewide HIE, which is under development by an organization that has had significant funding both through our state Medicaid agency, federal grants, including a recent grant from CMS for that TCPI project. And the other thing that we would look to for participation in this particular focus with these payers is whether or not there's a significant number of patients that are assigned to our health homes. In other words, it doesn't make any sense to start tracking and if there's only 20 patients assigned to a health center and everybody else is in the primary care practice affiliated with that hospital. What we would really be looking for is to make an impact on this delivery system and the transformation of clinical care by knowing that we could track on the numbers and actually recognize measurable results based on that. The community-based hospitals, for that reason, we would also look kind of as a numbers there that we would reach out to those hospitals if across our network, so in an urban area where we might have multiple health centers, we would look to those hospitals that probably interface with multiple of our health centers for that reason. And then the payer, obviously, we would need some sort of agreement. The payer would have the agreement with the Collaborative Ventures Network as the CIN, and the CIN would have these sub-participation agreements, memorandums of agreements with the hospital. And that around this value-based, the improvement of the outcomes, rather than the payer trying to negotiate with the hospital and with the health centers and being in the middle of it, we would rather have the clinically integrated network have that agreement with the payer, and we drive the change with all the participating providers, both PCP and hospital. Relative to exit criteria, since our health centers definitely have a mission to provide health care to all underserved patients, regardless of payer, we need to appreciate the fact that they may have to voluntarily exit if it allows them to focus on their own priorities relative to their health center needs. And we would also expect them to evaluate the return on the investment of their resources that is enabling them to address this requirement of the providers to be able to reduce the utilization. And certainly a lack of data can jeopardize any of this effort. So there's another reason why we would want to exit this agreement with the payer and or with hospitals if there's not a true exchange of health information. So in addition, and I know there's already been discussion around, the major breaches of a contract, but obviously we would look at any major breach. We would allow voluntary termination as an exit. And then looking at the reduction or lack of statistically measurable data across the patient base as a reason. And maybe that's the SIN giving notice to the health center, not so much the health center recognizing it initially. And certainly lack of any actionable data from the payer or lack of that information coming from the hospital. As far as accountabilities and roles, looked at this across those three parties. So the clinically integrated network, meaning the primary care health centers, the community-based hospitals, and then the payer, and what everybody has to participate in. Since the community health center is really the patient-centered medical home, we see our primary care providers as really the cornerstone of each patient's plan of treatment. And even at the time of an acute episode of care, we believe the primary care providers have the responsibility to engage in the oversight of the appropriate delivery and referral of other services that meet those clinical needs of their patients. For that reason, with the clinically integrated network, these primary care providers would be responsible and have accountability for access to care. That means providing credentialed providers, staffing, office hours, all of those kinds of things to meet the needs of the payer-assigned enrollees. They need to be able to have ongoing patient outreach and engagement in self-management of their health conditions. They need to adhere to protocols for voluntary and involuntary ER visits and the follow-up to those ER visits, and adherence to the protocol for 7-day and 30-day follow-up to any voluntary or involuntary admission, and that would be all causes. And then adherence to protocols around prenatal and postpartum care. Again, being primary care, we would see that there would be probably a higher level of obstetrical care in this group. For the hospitals, hospitals are going to be responsible for any voluntary and involuntary episodic care while the patient is under their care. And therefore, they also have a responsibility to return a patient to his or her medical home at the close of each episode. And while they take on responsibility for the plan of treatment during that episode of care, it's critical that they exchange all relevant patient health data with the clinically integrated network to ensure continuity of care and minimize duplicated or unnecessary follow-up procedures. The hospitals then need to participate in joint conferences between the network and the hospitalists, and this would be community-based, obviously, but to make sure that those primary care providers and the hospitalists are in agreement relative to clinical protocols and pathways to care. They would be required to notify the payer and the clinically integrated network of any emergency utilization, the ED visits. They would have to have also a mechanism there for notifying the payer and the clinically integrated network of any newborn deliveries and any other admission, discharge, or transfers related to hospitalizations. And they're responsible for the discharge planning and care coordination with the primary care provider, any referral providers, and the payer as well if prior authorization is required. And then participation in any post-acute, inpatient, outpatient medication reconciliation we think is going to be critical in this area so that we can reduce costs related to the overall cost of care. And possibly readmissions, because if there was non-adherence or something in the reconciliation that came to their attention, that we had misaligned medications. For the payers actually have the fiduciary responsibility for underwriting the patient's healthcare needs. They're not the healthcare practitioners. So responsibility to the network should be really limited to providing actionable data on enrollees, including the clinical care provided across the entire payer network. They also have to convey and exchange any healthcare outcomes that have been attained, and then the cost of total care to patients in the insured population so that we can continue to track on that as well. So their more specific responsibilities as a partner is to identify the high-risk enrollees, including high-cost, complex diagnosis, or record of noncompliance. They should have requirement for timely notice to the primary care of any ED visits and timely notice to the PCP of any newborn deliveries, admissions, discharge transfers, and then other notices of actionable clinical data. For example, if there's any patient self-referrals, especially if they go out of network, And then if there's any pharmacy benefit manager reports that would provide us an indication of either misuse or misalignment of medication. And the payer should also be responsible for providing a full patient clinical claim file to the clinically integrated network so that we can analyze opportunities for further quality improvement. And all of us working together collaboratively need to ensure that healthcare is delivered, the typical right time, right level, right care. This requires us to ensure our participating providers and partners agree to and are involved in the development and implementation of clinical pathways and protocols, the exchange of health information, and commitment to patient engagement. And for this purpose, we would require and have a responsibility for participation in regularly scheduled joint conferences so that the clinically integrated network would bring their community-based providers, both that are under contract in the clinically integrated network, as well as the hospitals that the patients are being admitted to, and the payer together to talk about these high-cost, high-need cases. Under performance incentives, we divvy this up between pay for performance and shared savings. Pay for performance, we think, really needs to be at 2 levels. Certainly in the first year, as this is being mapped out, and maybe it's, the initial part of the memorandum of agreement, is to really set up the administrative protocols and to have people meeting those administrative protocols. If possible, it would be nice to get to pay for performance on clinical and quality outcomes. We don't know if that will actually be measurable in the first year, but if everyone is adhering to the administrative protocols of reporting and joint conferences, then there should be some sort of remuneration for that participation, because we should recognize that it is already probably working towards driving down the utilization. And then on the back end, certainly shared savings across the board for being able to do this. So whether you're the primary care provider in the clinically integrated network, whether you're the hospital under the memorandum of understanding for participation, or the payer themselves for being able to supply actual data, there would be the opportunity then to share in savings. As far as the terms of low performance or what happens in that event, we also recommend a corrective action plan. And whether or not that may be fulfilled, if there's continued low performance in the same measure, it may result in termination. So getting through that initial corrective action plan doesn't mean that you're, saved. It would, if it continues to come up, you may be eliminated from participation going forward. And certainly any unresolved issues that come out of that corrective action plan, or something where a health center, hospital, and or even the payer is not being responsive, that would need to go to the governance level of the clinically integrated network to make a determination of how to adjudicate or mediate and adjudicate, and then with their recommendation for action, whether it's termination or some other kind of change in the agreement.
Okay. Questions? Feedback? Well, you guys are thinking about it. So in the context of Arizona, you have the regional behavioral health organizations, and they hold financial risk for people who live with serious and persistent mental illnesses. So what's the thought about their participation or partnership kind of accountabilities and roles?
Well, the state very clearly defines what their roles and responsibilities are for that Medicaid population. So those contracts are actually with our state Medicaid agency.
Mm-hmm.
And the interface with primary care, they are financially responsible for that as well. So we have integrated clinics. In fact, there are 4 of our members that are integrated clinics. under that, and they do serve the seriously mentally ill. There are other behavioral health providers in the community that aren't necessarily part of our organization because they're not federally qualified health centers. So some seriously mentally ill individuals may be assigned to primary care providers, which are behavioral health based. In other words, their primary provider is a behavioral health provider, not a community primary care provider.
Mm-hmm.
So in this realm, I didn't, I guess, pick up that you were talking about behavioral health hospitals as well as acute care.
Oh, no, not necessarily. I was just curious. I mean, we're just kind of generally curious about, and we've had conversations through the Learning Collaborative about, how is it you decide who you need to integrate with? And the answer, well, it depends in part on who you're trying to serve and what sorts of characteristics that population would have and the types of services that they would need. So
right.
It was just more a curiosity than anything else.
Yeah, and we have, our state Medicaid agency has also proposed to CMS to develop a district program. And under that particular program, what they have proposed is actually, it would become a clinically integrated network, and that would be the district entity. So, and it'll be regional based.
Okay.
It does not do away with the REBAs or the MCOs on the acute care side, the REBAs on the SMI side, the managed care organizations on the acute care side. What it does is it puts a layer that creates that connectivity across the networks. So what the state has proposed is that there would be a district entity that would be made up of providers, hospitals, other community service providers, so they're not necessarily clinical providers, but it's those that might provide services for connectivity to shelter, food, the other requirements of living. And what will happen is if somebody is identified by our state Medicaid agency as being identified as high need, high risk, they would be assigned through a registry process to one of these district entities, and it is up to that clinically integrated group. I say clinically integrated, but it would also include, like I say, some of these community social service organizations as well. It is required for them then to create a single plan of treatment and to manage that plan of treatment. And it's my understanding the state is looking to our HIE not only to be the data repository for all of the health information, but to also, it already has acquired a population health management tool to layer on top of that. It will then look to acquire a care management tool in addition to the pop health tool. So the care management tool would help to create a single care plan for those individuals.
So in this case, Access is kind of brokering a consistent framework, at least for the Medicaid side, around
it's kind of
tools.
Yeah, the initial way that the individuals came together to discuss it was that the state and we at the Alliance for Community Health Centers is our PCA here in Arizona. So Collaborative Ventures together with the Alliance kind of responded to the state as stakeholders. They indicated that federally qualified health centers or any provider should only join one district entity because each district entity, it was kind of odd the way it was worded because it appeared that each district entity would be designing its own care plan mechanism in their own protocols based on the patients in their registry. It seemed to us rather odd that when we take care of a significant number of the individuals that are enrolled in Medicaid, like about a third of them, that they would exclude a federally qualified health center from participation in any district entity for which its patients were registered. So we've countered the state on that one, but effectively the state in its original plan to CMS, didn't indicate it was going to drive the solution as a single solution. It was expecting the entities to drive a solution to meet the patients enrolled in each of their registries. I'm hoping that, personally, I'm hoping that changes to be a single solution. That was something else we also commented on. Because I don't know where you land 2 years from now when all of a sudden you have 6 different systems operating. As in, protocols and pathways. It would be much easier if you kind of outlined what that looked like singularly, so that if a patient moves from one registry to another or changes providers in that process, moves from one part of the state to another or whatever, and doesn't all of a sudden change that entire management of the individual's needs.
Right. Well, good for Arizona for doing that, because, we're seeing other places like New York where, there's certain commonality among the PPSs in terms of frameworks, but, everybody picks their own tools, technologies, pathways, structures, and, that has good points and bad points.
Yeah. Well, the district project was not approved by CMS on October 1st for this, individual year. It may get revisited by March. As you all know, we're waiting anxiously to see what the new executive branch has in store for us. And depending on where that goes, it may tell our Medicaid agency whether or not they have any hope of those discretionary funds to roll this out or not. In the meantime, we certainly take to heart what it is they were attempting to do, and that's why in our clinically integrated network, we do want to support a single care plan that could be utilized for our patients from their patient-centered medical home and then across the provider networks of the different health plans that we interface with. And we have close to 50%. We've had Medicaid managed care since the 80s in Arizona. So we have close to 50% of our population is in Medicaid managed care. Ironically, a lot of the state agency and the health plans have integrated shared savings and pay for performance long before they really addressed clinical transformation. So we're playing a little bit of catch up in trying to get the horse in front of the cart rather than the cart in front of the horse. But we have had our health centers successfully participate in ACOs and in those pay for performance and shared saving contracts with the Medicaid MCOs. So we see those as kind of our advocates for moving this forward and recognizing that clinical transformation is necessary and that we need to establish a real definition of value-based care for our group of providers.
Okay. Any other questions or comments for Collaborative Ventures Network?
Yeah, this is Leanne. I'm wondering about the single shared care plan that you mentioned. Do you have any idea where that would be housed?
What we're looking at right now, there's some federal funding that came available this last year to our health centers. The number of health centers, along with that shared savings or that budget, and their potentially a capital call, we're looking to invest in building an infrastructure for a clinically integrated network that will take feeds clinically from the Health Information Exchange and then build upon that our infrastructure for the financial piece and care management. So what we'd like to do is actually house that care management platform. It may be cloud-based, but you know what I mean, that we would be the centralized service for that cloud-based or care management service, and then they would access it that way, and we would see how we can link in those other providers, whether it's a hospital specialist, whatever, to feed that information. I think part of the care management plan we're also having, and actually I have to leave this call and go straight over there to our statewide HIE. If they are going to be able to move forward, we're not sure on their timeline on bringing in a care management piece on their top of their platform, so an application that will lie on top of their platform. If they can house it there, that would be great, because then anybody who accesses the HIE could be able to go in and with a responsibility for that patient take a look at that treatment plan.
Great, thank you.
And it would be fed by the HIE then. So I think that's the critical thing, is the timeliness of the data.
Okay. All right. Healing Community Center. Let's pick on you. Is anyone from Healing Community Center?
Hi, this is Karen. Sorry, I had you on mute. Sorry about that.
Hey, Karen.
Hey. So yes, let's go down the list for us. We have a ER diversion for oral health and physical health that includes our Indigent Care Hospital and 2 other FQHCs. And who can participate are those that have a buy-in and an integration, patient-centered medical home integration with ER diversion with the Indigent Care Hospital, which is, as I just mentioned, our Indigent Care Hospital and 2 FQHCs. The criteria to exit would be not having the ability to share the information, not having the ability to integrate with data, and not having ability within the structure to refer patients. Partner accountabilities and roles, top 5, includes time of commitment to the project and to the effort, organizational culture, integration of the services, by it being with oral health, ER, and physical health, whether there is a point person to handle the referrals, both to go out and to receive by the FQHCs, for getting those individuals into a patient-centered medical home. 4 criteria, top accountability roles would be data shared. If not on the same EHR, a bridge or platform that can be shared to use real-time data for information on patients. And then 5, the involvement of key management individuals for decision making, and the MOU being a binding legal document that incorporates all of the partners in the CIN. And performance incentives are cost sharing as well as savings. We are looking to reduce the recidivism of, or shall I say, utilization of patients overusing the ER, so thus decreasing for the Indigent Care Hospital, while also creating a patient-centered medical home with the FQs for those patients who are presenting with primary care needs. And let's see, what are the terms? The terms are, for low performance, is reevaluate why the performance is low. Is there a challenge with patients getting to the referral site of the community health centers? Is there a problem on the end of the ER with having staff to direct the referral? But once it has been determined what the challenge is, then the process will be evaluated, and should any partner decide to terminate their agreement with the MOU, there are stipulations in the MOU for a time frame for exiting, with a proprietary information clause of not sharing the information that is shared with the cost savings or payer vendors, or with information of the patient themselves. The rationale is for continuum of care, for vendor savings, payer source savings, and a patient-centered medical home for patients that are in need. And there you are.
Wow. Okay, so that's the first time we've talked about. Okay, if you leave, if you back out of the integrated network, you have to keep your mouth shut. no sharing of terms, conditions. How did you think about that one, or what caused that one to come up?
Well, because through the involvement, and we've actually been involved for some time, that you start to become a part of the other organizations, such as EHR, purchasing costs. There are a lot of proprietary information that is shared in this network or collaboration, that even as simple as negotiations with lab costs. So there's a real effort to share information for better care and continuum of care. So those particular elements would be safeguarded by the organization's agreement to not share, to go to, once you leave the organization, to go to one of the vendors and say, well, I know they have a rate of this or that, but that information is only shared because you become a part of the network.
Okay. So there is a balancing of, like, how much do we get to know each other? Maybe we get to know each other a little too well. We have to respect what we do as partners in this integrated effort.
Yeah, and I think that's only fair. We're asking individuals to come together for the sake of better health care, and though there is some benefit to each of the organizations, but even in that, in order for the individuals to remain whole, should an organization pull out, since you're so closely related in the city, and oftentimes just a few miles apart, could prove to be challenging for the other organizations that remain in the CIN.
Okay. All right. Questions for Karen? Comments? Feedback for Karen? Tightly organized. Thank you. Okay. Hudson River.
Hi, this is Megan. Like others, I've sort of, even though it's, the assignment was a mock partnership agreement, I've based our responses largely on our existing operating agreement for our IPA. And in that agreement, the participating entities are, we have a 50-50 ownership structure, and 50% of the IPA is owned by Hudson River Healthcare, which is a federally qualified community health center. And the other 50% is owned by a collaborative of behavioral health organizations and that provides care in the same geography that we do. So that's the terms that exist under the current operating agreement, and there's a requirement that each side would need to capitalize the corporation in accordance with what the working capital needs are. However, I'd say we have had hypothetical conversations about whether we'd be open to including other providers, which we are. But we would really want to gear our network towards FQHC providers, community-based behavioral health providers, possibly other non-FQHC partners that were serving a large Medicaid population and committed to serving in a safety net capacity if one were interested. But that sort of just describes what the current state is and what we've discussed as possible future state. Exit criteria that are articulated in the operating agreement are that a member may voluntarily withdraw with 90 days notice. They would not be entitled to any compensation for the interest that they're paid into the corporation, but they may be able to be repaid contents of the capital account if that were approved by the board. So members can exit at any time as long as they give sufficient notice. And then in terms of partner accountabilities, I actually really here only articulated three. So the first one being governance. The owners of our IPA, each of the 50% owners have 3 seats on a board of managers, and so they're responsible for populating those seats. Just for what it's worth, the officers of the corporation, the chair, vice chair, secretary, and treasurer, those positions are specified in our operating agreement that the chair and the secretary position are occupied by one of the partners, and then the other seats of the vice chair and the treasurer are populated by the other 50% owner partners, and then those seats switch every 2 years. I'm sorry. So they have term limits on the chair, vice chair, secretary, and treasurer. And so they're up every 2 years, and which entity is eligible to populate those seats switches. So for primary care right now holds the chair and the secretary position, and behavioral health holds the vice chair and the treasurer position. In 2 years, we'll switch those, and behavioral health will chair, and primary care will vice chair. So in addition to governance, there's also a responsibility to provide the necessary working capital for the corporation, and whenever that's deemed necessary. And of course, to provide service delivery that's consistent with performance targets. And those performance targets would really be driven by the specifics of any value-based payment arrangement that we enter into with a managed care organization. The current agreement that we're working under has some specific performance goals around reducing non-emergent emergency department usage, and a set of 8 quality measures that we're also responsible for performing on. In terms of the performance incentives, this was probably the most difficult question for me to answer, because this is exactly what our technical assistance that we're receiving under SNAC is focused on, helping us to develop a methodology to distributing any shared savings that we might be able to earn. So, a simple method that we might do if we were just creating a mock agreement would just to say, since it's 50% ownership, we'll just distribute the savings 50-50. But we're really working with a technical assistance provider to try to develop a more nuanced approach to that would take into account the level of effort and impact that the various different provider types may have on achieving those performance targets related to reducing non-emergent ED use and improving performance on those 8 quality measures. And so that's the process that we're in right now, and we're taking a close look at that. And then lastly, what are the terms in the event of low performance? I'll have to say that our actual operating agreement didn't have specific terms on this, so I just drafted some mock ones for purposes of the assignment, saying that, we really wouldn't want low performance to result in anything like immediate expulsion, so we'd want some opportunity for improvement. So I had drafted a sort of stepwise process where first an entity would have to go through a remediation process, and then if after remediation there was still low performance, there might be sanctions that were associated with low performance, and perhaps you might impact some of their distributions from any shared savings opportunity. And then lastly, if a low performer were unable to bring that performance up, we might have to look at expulsion from the network.
Okay. So you're actually thinking about, what to do in terms of what are the terms in the event of low performance with, you're linking that with performance incentives. And was that a deliberate kind of, is that why you want a more nuanced approach to aligning performance incentives?
We're looking on the first thing on why we're looking at a more nuanced approach to performance incentives is because of the diversity of provider types in our IPA. Mm-hmm. So, because we have both primary care and behavioral health partners providers within our IPA. So, if you might look at if you had a pot of shared savings and how you might distribute it among the providers in the IPA, if we did it off of attribution, that's not particularly fair to the behavioral health partners because they don't drive any attribution under the model. It's all primary care attribution. If we did it by just, percent of ownership interest, 50-50, there are some who feel that that's not particularly fair to the participating providers either, because there are some quality measures that are very clearly behavioral health focused. There are some quality measures that are clearly very primary care focused, and there's a desire among the providers in the IPA to develop a methodology that would take into account how, even though we're working on integrated care, if there is a higher level of intensity of work and impact that one provider type would have on a particular quality measure over another, and you might see very high performance or very low performance impact the overall pot of shared savings, that the distribution methodology be consistent with that level of effort and impact.
Very hard to have integration without alignment.
Yeah.
Yeah. Megan, this is Sherry. Just a quick question. Is part of some of the things that you're looking at around the shared saving distribution just related to a certain percentage being set aside for infrastructure needs that go back into?
Yes, we're definitely, there will be some portion that gets retained by the IPA for ongoing infrastructure needs, absolutely.
Very good. I hadn't heard anybody talk about that today, and I was just wondering, so good. Okay.
Thank you for mentioning that, because yes, that's definitely part of it.
Okay.
So any questions, feedback for Hudson River? I'm curious, how long has your IPA been up and running?
So the IPA was initially got started in late 2014, early 2015. That's prior to my joining. And so they actually, filed the paperwork with the state at that time and continued to work on, various parts of the administrative infrastructure there. They hired me. I started in the beginning of October of 2015, and we were involved at that time in early stage discussions with a couple of managed care organizations about a value-based payment arrangement, and then our first value-based payment arrangement, which is short-term in nature, started on July 1 of 2016.
Okay. Questions, feedback for Hudson River? Okay. Southern Illinois.
Is my mute off?
Okay.
My cell phone.
Here you are. Here she is.
So basically, who would participate in under what conditions? So we have we have two major hospitals in the area, and we're closely aligned with one of our local hospitals, and they also own our community mental health center. And they also own the building that our FQHC is in. So it's a very close pack that goes on. So it would be those three entities, the mental health center, the local hospital, plus also their physician group. They have a physician group, plus then our FQHC center, which the complexity comes in because we're an FQHC center too. So, and I bring that up because just today we're dealing with the issues that have arose from that. So our mental health center has placed 5 behavioral health consultants in our clinic. And then we have a primary care physician who runs an integrated clinic at the mental health center itself. What we're struggling with right now is we have to teach because we're an academic center, and we need to teach behavioral health. But that does not bring in revenue. So we're looking at contracts today to determine how do we assign and align our academic needs with the integrated model. And so that's kind of where my mind has been today. So, but I think that brings up a whole different arena as we talk about things. That group is together, again, because we're closely aligned, but we also all address a different complexity of patients we've identified. So for my FQHC, we're very good at handling patients that are very high and social determinants of health have a large array of complexity in their home life. While my mental health center is, their coordinators are very good at severe mental illness. And then the hospital has care coordinators who are good at dealing with those who have insurance that also have some behavioral health component. So we created a tiered assignment level based upon the level of patient complexity. And that's how then our performance incentives will probably be based upon a pointage scale for patient complexity and level of impact that results. Our patient accountabilities and roles, our local hospital is driving our data retrieval. They've built their own internal system, and our EHRs are also all connected. So they run our EHR system. Our academic center is the one who drives the data analysis, though. And also the academic center kind of is monitoring all the population characteristics and any cohort changes that occurs. The mental health center, their biggest role for us right now is to figure out how to maximize our billing of those who are our care facilitators and our behavioral consultants. Because we know that we can bill differently under the FQHC for some folks, and we can bill differently under the hospitals for some folks, and we can do that differently for the mental health center. So we're trying to align contracts and hiring so we maximize billing efforts. Our performance incentives, as I said, we're kind of having a tiered reimbursement process, but we are shooting for at least a 28% reduction in non-emergency ED visits. We have shown our groups have varied from 20% to a 68% reduction rate, and so we're saying if together we bring those groups together, we want to at least achieve a 28%. Same thing with readmissions. We're looking at that. We really looked at our preventive care access and increasing the different types of clinics that we offer and the number of patients who are getting into those and engaging. And let's see what else. I'm trying to think of things that I don't want to repeat everything. And so for our exit criteria, that's probably the most difficult thing for me because we're just currently forming our group with the hospitals and everybody who's really looking at this to formalize it. We've all piloted it, and now we're bringing it together. And so we have 3 members from each of those entities that I talked about that are making up the board. And our first meeting for this is in January to finalize what this will look like. So some of those things probably will come up at that point. That's not the area that I have really focused on so much in my work with them. But I do know that we've based a lot of this initially around MOUs is what our process has been. Trying to see if there's anything. We currently are piloting a shared care plan between our entities to see how that works. And that has probably been one of the most difficult things because we each are looking for something a little bit different, and we're trying to come to an agreement on that aspect. But I think that's a really quick summary. I know we're starting to run out of time, so questions, things you want me to explain more?
We're actually okay. We have, so this one is a little bit longer. This one we could, we're scheduled to go until 3:30 Central. Unless we want to go shorter. So I don't want anyone to feel like, whoa, holy cow, I've got to speed through this.
Our low performance, what we are really looking at is we've identified a consultant standard so that if you're not meeting performance requirements, a consultant that is all agreed on will come in and analyze the clinic formation and the other indicators using a prescribed checklist. And then the recommendations will come out of that. And then if there are issues in addressing those recommendations, then we have set into sanctions and fines. And eventually then if you can't comply, it would lead to termination. But again, I think that the complexity for us comes that it's all fitting within a system. There's an connectivity between the systems. So they right now don't stand alone necessarily. A lot of financial pieces coming from the hospital that's managing a lot of these areas.
Okay, so yeah, it sounds like the hospital is really playing a bigger role in data sharing, data analysis, which kind of powers the system overall.
Right. I was going to say, I think, our hospital is one of our biggest, is the biggest central factor here. And they had one of our Medicaid expansion programs that they managed for a while. And so that's where they have gotten all this data capabilities and stuff at.
Okay. And so with kind of an anchor partner like that, what are your prospects for being able to grow the network and integrate with more and other types of service providers?
So the thing for us is that we have our other FQHCs all across our southern state. And then our hospital has 4 other hospitals which they own across our state, too. Together we align really well. But because it's an healthcare setting, we have all levels of providers engaged in that process, and also their physicians group is all levels of providers. And so we have just assigned, and I just took on the role of the clinical integration director. And so that role is to bring all those pieces together so that we can have shared care direction. I don't know if that answered your question or not.
Yeah, so you've got a universe in which you can grow.
I mean, I think
the unique structure of.
And since July, we've had a whole restructure of our organization to allow for that growth. And it's being very driven by the hospital. But what the hospital has found out is they don't have a skill set to manage, 30 to 40% of their clients. They just have not been successful. And for the last year and a half, we piloted them transferring or giving those patients to my group. And we've managed those, and we're very successful. So they need us in that rate. So we kind of found what our strengths are in each group and have brought that together.
That's great. Awesome.
Questions, feedback for Southern Illinois? Okay. Last but certainly not least, we have VNA Healthcare. Laura, you ready?
Yep, I am. I'm hoping my voice hangs on here. I've been getting over an upper respiratory thing, so if I talk a lot, it starts to cough, so I will do my best here. We are not nearly as far in this process as any of the previous presenters, so when I'm talking about this truly is a hypothetical mock partnership agreement. And the area that I chose with ours is we are spread over, we have 10 centers and clinic settings. We're federally qualified, and we're over 3 counties, and we have 10 sites. 2 are in 2 major cities here in northern Illinois, and the western suburbs outside of Chicago. And one of the areas that we're really trying to get a handle on, I think, I'm working collaboratively with our behavioral health services here and with the local hospital system that actually has 2 behavioral health services for inpatient and outpatient near our 2 largest populations in our communities that we cover. So my hypothetical here, mock partnership agreement, is to work with those inpatient behavioral health services with the VNA. And so we've already identified, we have some disconnects with the inpatient going into the outpatient setting there with it. So I think this is a good opportunity to help improve getting those patients set up for post-hospitalization follow-up, and then to be maintained with medications and ongoing outpatient treatment with that. So again, we're trying to decrease that inpatient utilization and ultimately the emergency room use also with that. So we identified inpatient behavioral health service patients. working with the transitional care nurse for transition from hospital to the VNA clinic. Currently, we know we have about a 65% no-show rate from those patients from inpatient coming to outpatient with that 7-day follow-up that we are expected to adhere to with our managed Medicaid plans, and it's a state requirement too with it. So that's our goal that we're trying to improve on and work collaboratively through a clinically integrated network with this hospital system. So that would be who we would want to be participating in and under what conditions we'd be working with right now. What is the exit criteria? I'm not going to repeat a lot of, but I took a lot of notes here on a lot of the previously stated pieces because there was like little good tidbits in everybody's report today that I just could hold on to. So my areas that would change or to add into that was we want to make sure there's some kind of contract with our managed care organizations that we're also contracted with, so that would be important to be able to have that shared savings piece going forward with it. Of course, all the legal requirements, notifications, we have MOUs in place with these organizations already, so re-looking at those and then taking that into that next step with that clinically integrated network. With that, so that's where I left with that for additional thoughts. Partner accountability rules, list your top 5. What we were looking at is identifying patients as part of the VNA through their primary care, or possibly they don't have a primary care medical home or they're not identified with a PCP to be following on up with the VNA. So that would be a part of the process for the inpatient behavioral health services that would be working with them more collaboratively. Provide discharge packet at time of follow-up appointment. So what we'd be looking for is when the patient still is an inpatient, we'd be looking to setting up that discharge appointment time, giving that appointment card to the patient. And then at that time, we would also, so it's that sharing of information. So whether that can be done electronically through the EMR or access to the EMR, that would be the ideal piece. I'm not sure we're completely clinically set up to be able to handle that, but we do have some secure ways we can process that information back and forth, but that would definitely be a top role that we would have to share that documentation back and forth. And we were looking even at setting up like an appointment card system for scheduling, so when patients are discharged with the case manager, transitional care nurse at the inpatient setting, we would actually physically hand them an appointment card with their date and time that they would be coming on in, and that information would be then in our system that we would then be tracking and following up with that patient. So number 4 was improve post-hospitalization follow-up. We'd like to, instead of having the 65% no-show rate, our goal would be to be at 65% show rate for those follow-up appointments there with it. And then the 5th thing is VNA is to provide follow-up statistics monthly to the hospital system. So we'd want to be tracking this for quality initiatives, and that comes underneath those performance initiatives. So we'd have to be tracking this at least monthly with this, looking at whatever opportunities we have to make those improvements. And that kind of gets us into those performance initiatives that I identified. With that shared savings, we'd want to be doing working with those MCOs to see if we can improve our outcomes on that, and then ultimately receive some of that shared savings amount. That's where I was kind of I didn't know how that was set up, or if anyone's had any experience with how you divide up the pie, so to speak, when you get to that shared savings. So that was a question I had for the group, maybe to help me identify if there's any standard out there that's being used with that. Ultimately, you want to show that you're reducing your ER visits. The patients are maintaining their medications, so that medication reconciliation and going through those different levels of care from inpatient to outpatient settings, that those meds are filled, maintained, they follow within their formulary for their plans, and that the patients are taking them and filling them on a regular basis. And then treatment for an outpatient basis, we'd want to be monitoring and watching that. So what are the terms in the event of low performance? One of the things we'd want to be watching is quarterly review of progress. So taking those monthly reports, reviewing that to show where we're moving towards reaching that goal of 65% show rate. Those no-shows would need to be reviewed and looked for a deeper dive, I call it, into that data to identify what was the cause for that no-show. Did they reschedule that appointment when it was outside the 7-day window? Was there transportation issues? Did they go see another provider possibly so they actually did meet the 7-day goal, but maybe it wasn't with us for some reason? If there's schedule limitations, which is a huge barrier right now for us in mental health, we're just booked out so far. There's just not enough providers to handle all the volume of patients that are coming out. And then re-looking at those schedules and opportunities to use that no-show rate to where we can get those patients in on a timely manner. Use of a community health worker to go out to find patients when they don't show up and they have not called and they've not rescheduled with that. And also looking with that community health worker and with the inpatient case manager and the staff at the clinic here is also reviewing during this time social determinants that might be preventing that patient from reaching. Maybe they're homeless, maybe there's financial scarcity, that there's problems getting their medications filled, and working through those issues so that we can make sure that the patient's as successful as possible. Third thing underneath terms for low performance is develop identification of possible no-show reasons at the time of hospitalization. So in other words, after you take that deeper dive, look at those reasons that they may not have been showing up, then going through and then working with the inpatient case manager so that we can have more pointed, specific questions to make sure that patient is going to make a successful transition from inpatient into the outpatient setting. So questions can come up about housing, finance. Are they going to be able to fill their medications, get to the pharmacy, fill those on a regular basis? What do they have for reminders to tell them to take their medication? And what happens if they don't take it? Do they know if they can take that medicine on an off schedule and how to get those pieces put together? And then finally, lack of engagement by another reason for low performance would be lack of engagement either by the hospital organization and or the VNA, that we would have that. And so it goes into those agreements that you talk about, giving the 90-day notice, giving the information there if they change their health plan so that they're no longer contracted with those health plans. We would have those written in there for that reason to be able to leave with each other. So I know that was probably a lot more talking than I probably needed to do, but those are the areas that I came up with, and where I went with there, again, we have no point of reference for this right now other than our discussions that we've had with this group here every 2 weeks for the last 3 months. So, I'm open to any comments or thoughts on this.
Hey, Cora, this is Sherry. Oh, sorry, Natalie. Go ahead.
No, go ahead. Go ahead.
Just a quick question for you. I know one of the things that you mentioned that I think might drive a little bit of outcome is related to the access issues you were talking about within VNA. What are your thoughts around trying to address that?
The access issues are coming to the clinic post inpatient hospitalization?
Yep.
Yep. Well, we are physically 9 blocks away from the one hospital. Our biggest hospital, our biggest location where most of our patients end up having inpatients. So physically, if they're able to walk, they could literally walk down the street here with it. What we're finding, though, is we still have a 65% no-show rate. So that's got to be one of our, biggest challenges. We're located on a bus route, so transportation should not be the piece that's holding back on that. And we even have, for those MCOs, they all have free transportation. So as long as they give them at least a 2-day notice of the date when their appointment is, they will physically come and pick them up at their home and drop them off at the clinic and take them back to their home with it. the transportation should not be an area that should be a problem with that. I think sometimes there's a cost possibility with that, and sometimes I think it's just the underlying mental illness that's going on that's preventing them from taking that next step. And hence, that's why I think we need to engage in, and I do have this going on in some other areas, is using like a community health worker to go out and do a well-being check at the home, verify that they're there, did they pick up their medications, and then helping them actually right there at the home reschedule that appointment if needed.
This is Tracy from SAU. And I'm going to say our community health workers, we have now our engagement, our show rate in one at 98%, one at 87% by our community health workers.
Awesome. That's awesome. That is truly awesome. And that's where we see with our OBs, with our peds and newborn appointments, where we use that role there, we're getting around 98 to 99%. We had, 803 deliveries last year with peds patients, and all but one of them showed up within 24 to 48 hours postpartum for their newborn well check at the clinic. But in behavioral health, it's just a different breed. It's really hard to get that group going with it. So
does the group have any feedback, pointers, recommendations, whatever, for structuring performance incentives? And in particular, Laura, I think you brought up the question of, how do you share gains, basically? And I think it's sort of the same conversation you're having, Megan, with as part of your SNAP grant. I mean, what's really the right way to structure that?
I can share with this is Jenny in Arizona. I can share with the group what is coming through on some of our Medicaid managed care contracts, because it's somewhat driven by the state. Each health plan is held to, and they have passed on to our primary care providers, 6 clinical quality measures, which include the inpatient admissions or readmissions, and then ER utilization, as well as primary care visits. So are the children getting in at their different age groups? They've not yet picked up on the cancer screenings or those measures that we tend to track on also for our UDS measures. But then what happens is each participating provider has a benchmark set for them. And if they reach that benchmark, I'm sorry, not the benchmark, but the goal. So there's a benchmark established, and then there's a goal. If they reach the goal, they can earn so many, cents on the dollar, or so many dollars per member per month. So it can be paid out quarterly for achieving that goal outcome. So that's the pay for performance part. On the shared savings part, what they've done then is they said, based on how many of those measures you meet, you get to participate in the pool. So a pool is established for the different providers, and then depending on how many of the measures you meet, you get to participate in the pool. If you only meet 20% of your measures, then you only get 20% of that available pool. Our problem is obviously the health plan gets to retain the rest when it's being paid out in that manner, rather than expending any additional resources to be able to improve the outcomes at the provider level. So there's still some discussion around how that might be handled going forward.
Now, the other tip, Laura, would be have the conversation and sort it out earlier rather than later. One of the experiences we've had here at Optum was that, we had every intention with a consortium of FQHCs to sort out what equitable distribution of gains would look like to really, keep incentives aligned and make some of those trade-offs that Megan was starting to talk to. And then we sort of let the effort languish because we got into doing the work, and the work takes a lot of time and effort. And then during our first year, we didn't think we'd earned anything, so it wasn't much of a discussion on how to really distribute the gains. And then unfortunately, or fortunately, in the second year, the group, the consortium came into quite a lot of money because it was discovered that there was gain sharing for year one. So all of a sudden, you think of it as a good problem to have. We earned a bunch of money, but then, how did you distribute it between 10 clinics? And it would have been better to have had the discipline to sort that through before there was money on the table, because after there was money on the table, there was also quite a lot of emotion, and so address it sooner rather than later would be our one big piece of advice.
Yeah, I agree. I think that just kind of helps set up the foundation of where you're going with it. So I do appreciate that. My guess is it's got to be broken down somehow into the resources that are being utilized to meet the goals with it. So and who's doing what resources with it. So if I'm sending out community health workers, that's going to be a higher level of involvement versus part of the expected discharge instructions that you're doing with a patient anyways with it, and getting prepared for discharge. So to me, like I said, I don't know if it's like a 40-60, if there's 20-80, 30-70, what is it that goes out there when what is the norm for that? My gut feeling is it's telling me that I have to work off the resources that are being utilized. And I'm not sure going initially, when you're setting this on up, you're going to even know how much of those resources, how many times will I need a community health worker? And maybe that needs to be just a temporary setup and then evaluated in one of those quarterly meeting marks to see what resources are being used. So that's what I was looking at.
And I think somebody made the point that over time you evolve this. So one of the things we said was, okay, we'll kind of live with this model for year one, and during year two, by a certain date, we'll resolve how we want to distribute gains for subsequent iterations of this, because you will learn over time. But it was marked as something to go back and consciously revisit, and it was assigned to the CFOs specifically as part of governance to come up with a model that followed a certain set of principles, and those principles balance between things like effort invested versus what were the performance results, and what was relative attribution. That was another component. Some of these may not be germane to your particular setting. In this case, we're dealing with a consortium of 10 legally autonomous FQHCs, each with attribution that varied significantly. And some of the clinics were much better resourced than other clinics and had some of the money to invest in care coordination model support. So expect a dynamic conversation.
And this is Sherry. There really are no standards, so to speak, out there. I think the exposure that I've seen in the ACO market is anything goes. It's all around what the governance structure, who is in, how the governance structure is developed, and then hopefully that big component of the alignment of incentives. So, I've seen it all over the board where there's a full ACO with primary specialty hospital, and they say that the primary care docs might get 60% because they're the ones that are the medical home and they're doing a lot of the work to try to manage those patients. specialty is certainly a component of it, but they're going to get less. The hospital is going to get even less. And then there's always going to be a bit for the administration component, and so that can go back into the working of the ACO for success, whether it be infrastructure needs or more resources, people resources, whatever it might be. But the numbers is how, as far as how they play out, it's different everywhere you go. Those percentages.
One thing that's really important, though, regardless, is transparency. And being really, really open and having enough of a relationship to be able to discuss and share. One of our conscious decisions was not to get too far into the, really, how do we account for every unit of work that went into it, because then we'd have to build cost accounting systems and we'd be here forever haggling about it. So, we decided that couldn't be the only criteria. What was invested and what was a fair return based on the investment. Who did the most. So just transparency helped, though, and having the CFOs be really, really open and candid with each other. And we did modeling and we tried different assumptions in the model, and as the assumptions changed, we built the assumptions together and ran the model together, and so everybody saw the same thing, and I think that helped ultimately. Okay, other questions, concerns, feedback, discussion? You all did a great job on these. These were thoughtful, and thank you for being earnest about this. We really, really do appreciate that. And for those of you with more experience, thank you for sharing what it is you encounter on a daily basis in this value-based world we're jumping into here. Just to make sure that you know a couple of things. SurveyMonkey, please, if you can, fill it out. Let us know what would make this better, and what was valuable and what was less valuable. Also, AJ, I don't know if you've talked about this with the group, but there is a virtual resource center associated with SNAC. And there are a growing number of terrific resources on the resource center, the virtual resource center. So, AJ, I'm trusting that you're letting people know that that's available and how to access that as we go. Is that right?
Yep, and I'll make sure to share that with everyone in a follow-up email that's going to go out probably tomorrow. So thanks for pointing that out, Natalie.
Okay. Best of luck on your value-based journeys. Keep in touch. Let us know how things go. We've got our fingers, toes, and everything else crossed for your success.